Hey everyone, this is Brian Miller, one of your Associate System Medical Directors, and here today I get to talk to you all about pre-hospital stroke management. In this CE, as well as the next one, we're going to focus on a couple of time-sensitive diagnoses, and I really can't think of one that's more time-sensitive than stroke. What we do in the field really matters, and so we wanted to bring you a lecture on some of the nitty-gritty of stroke and some of our goals of care for that. So without further ado, let's move right into our objectives now. What are our objectives today? We're going to cover the pathophysiology, or the causes behind small and large vessel strokes. We're going to then describe the large vessel occlusion and the specific signs and symptoms that we need to look out for when we're out there. Next, we're going to move into our system's pre-hospital stroke screening and severity scales and how do we perform them. Then we're going to move on to our system's stroke care bundle goals and the critical actions we need to do on scene and en route. Then we're going to talk about some really important protocol changes that deal with stroke destination and where we take specific strokes. And then finally, we're going to wrap things up by talking about some specific stroke syndromes that are missed commonly with our normal stroke screening methods. So why do we care about stroke? Well, stroke's the #1 cause of disability in the United States, and it's also the #5 cause of death. I really can't think of anything else in the pre-hospital setting that has such morbidity and mortality that we can make an impact on. We've also been taught the time-sensitive nature of stroke. We've been taught that time is brain. But what does that really mean? So, for an example, for every 15 minutes delay in treatment of a large vessel occlusion, the brain loses about 28.5 million neurons. You got a few billion in your body. You also lose about 3 months of healthy life. So that's about 3 months less that patient is functional in their lifetime. Even more importantly, they lose about 12 weeks of overall lifespan for every 15-minute delay in treatment. And then finally, for those 15-minute delays, about 10% decrease odds of a good outcome, where they rehab and are able to go back to a functional human being again. And so this is really important when we think about the time sensitivity of stroke. When we're talking about stroke, we need to divide it into 2 categories. The first is your ischemic strokes. That's where you have a clot or a blockage of one of the blood vessels causing lack of blood flow downstream. The other side of things is your hemorrhagic strokes. That's where there's a leakage or a rupture of one of the blood vessels in the brain, causing bleeding directly into the brain itself. As far as the breakdown goes, ischemic is going to be the vast majority of the strokes we see, about 87% of the time. That's why we're going to focus on this lecture primarily on the recognition and treatment of an ischemic stroke. However, hemorrhagic strokes are still important. They're about 13% of the cases that we see. As far as ischemic strokes go, there's really 3 categories. The first is the thrombotic strokes. That's about 20% of cases. This is much similar to our MIs, where there's a buildup of an atherosclerotic or cholesterol plaque that finally ruptures and completely occludes the blood vessel. The second case deals with our small blood vessels in the brain, or our lacunar strokes. That's about 25% of cases. Those small little blood vessels are really prone to hypertension or high blood pressure effects, and as that wear and tear happens, there's a buildup of lipids that eventually narrows and occludes that blood vessel off. The third category is our embolic strokes. That's another 20% of causes. This is typically from the heart or the internal carotids. The heart, usually from atrial fibrillation or AFib, you have a clot that builds up in that heart and then gets slung off to the brain and finally dead ends into a blood vessel and occludes it. You can also have plaques break off from the internal carotids, and that can also get slung up into the brain. About 30% of causes, though, from stroke, we just don't know the cause. Those are what we call our cryptogenic or I don't know kind of cause stroke. And then finally, there's a category of about 5% of strokes that we really have other causes such as vasculitis or infection or a watershed or just bad blood flow to the brain during a critical hypotension event type of thing. So that's your main breakdown of your ischemic strokes. There's one more category we need to get down, and that's the small versus large vessel strokes. Small blood vessel strokes are usually in the deep brain in a limited area or around the brain stem. However, the large vessel strokes, as their name implies, comprise a very large amount of territory of the brain all at once. To understand stroke, we have to understand the brain's blood supply. And what you see on the left is the circle of Willis, or the main blood supplies to the brain. So in comes our internal carotids in the front from our neck that feeds the front of the brain, and then in the back of the brain along the spinal cord we have our vertebral arteries. Those 2 vertebral arteries then meet together and form a single blood vessel called the basilar artery that runs along the brainstem there. And then to the main parts of the brain, we have the anterior cerebral, middle cerebral, and posterior cerebral arteries that feed the vast majority of the brain there. These arteries have specific areas of the brain that they feed there. As you can see in the yellow, the green, and the blue areas, that specific blood vessel is dedicated to specific parts of the brain, and therefore when you have a blockage in one of those blood vessels, specific parts of the brain are knocked out then. Just like blood flow, there's specific areas of the brain that control specific functions. And so what you see on the left is the homunculus, or basically the body laid out on that motor strip, or the area of the brain that controls motor or movement function and where it occurs in each area. You also see on the right side the specific areas of the brain that are controlling specific functions. And so the areas that are circled there are where our stroke screens typically look. Areas for ability to talk, understand, and our face and arm type of functions. And then as you see, there's other areas that other stroke screens can look at as well. Now to bring that all together, we have the vessel and then to symptoms. And so here we have one of those small little blood vessels in the brain right there. And then on the right side, we see that all that motor function comes together right into that one area right there. So when we have a stroke, like we see in the middle there in red, that knocks out that entire area and all the motor function that came down into it beforehand. However, there's a tricky thing that happens. And so all that motor function then crosses across the spinal cord right there. So that's where when we see a right-sided stroke, we actually see symptoms on the left side then. It's because of that crossover of that motor or sensory function in the middle of the brain right there. Now let's revisit our lacunar infarcts or our small vessel occlusions. So these are in the subcortical or below the cortex or the outer part of the brain in the deep brain. So these are usually limited in nature, so therefore we usually have a one system problem. We only have one function going wrong. So you can think about this as a stroke sniper where it just picks out a small part of the brain. However, just because it's a small area doesn't mean it doesn't have big symptoms still. And so these are typically a pure motor stroke about 33 to 50% of the time, where we have weakness equally to the face, arm, and leg. Or you can have a pure sensory where you lose sensation of the face, arm, and leg. And then there's some less common stroke syndromes such as sensory motor, ataxic hemiparesis, and even just a clumsy hand right there. So still have a lot of symptoms, but usually a one system problem here. Now let's move on to our large vessel occlusions, or LVO or LVOS. So this is typically your middle cerebral artery strokes. And so as you can see in the picture, that has a huge territory of the brain that it feeds right there, so you can have huge damage. You can go a little bit more proximal or down into the neck, and that's your internal carotid artery stenoses or blockages, and that can cause even a larger stroke in typically the front half of the brain right there. You can also move to the back of the brain, and that's the vertebral or the basilar arteries, and that will knock out blood flow to the brainstem and the back of the brain there. A little bit more rare is the anterior cerebral arteries, and those are the front of the brain type strokes. So while we talked about the lacunar or the small vessel occlusions being the stroke sniper, this is like a grenade going off in your brain. It destroys a huge amount of area very quickly and very easily. Our large vessel occlusions affect the cortex or the cortical regions of the brain, and we can look for some specific signs that are telltale for a large vessel occlusion. Don't freak out if you don't know these words yet. We're going to cover them in just a second. So there's really 4 areas though I want you to think about, and that's aphasia, neglect/agnosia, gaze deviation, and visual field deficits. The first of these cortical signs is aphasia. This is the difficulty understanding or producing speech. This is not dysarthria. That's actually the motor function of the tongue itself, and that causes slurred speech. Also be careful with aphasia. This may be interpreted as an altered mental status or confusion, as the patient doesn't seem to be speaking coherently or using correct words. However, they're actually alert and oriented inside. It's their brain malfunctioning to actually produce the speech itself. The 2 main areas of speech for the brain are located on the left side, and that's Broca's and Wernicke's. And so when you have a left middle cerebral artery stroke or MCA stroke of the left side, that knocks out the left hemisphere and causes a knockout of these areas, and that's where you can see those cortical signs of aphasia. There's 3 types of aphasia that we should note. The first is expressive non-fluent aphasia. This is where we have inability or difficulty speaking. Speech is really effortful and halting. The patient speaking like apple. And so you know what to say, but they're very, very frustrated and just can't get the words out. The middle category is receptive or fluent aphasia. So this is the inability to comprehend and understand. So the patient's just blabbing on nonsensical, not on topic, and meaningless speech. They're just talking away with no difficulty, but they really don't comprehend or understand anything in. And so due to that, they may not be able to follow commands. And even more frustrating is they don't know that their speech doesn't make sense. They think they're having a normal conversation that everybody else is understanding. The final category is the global aphasia, where there's a combo of inability to speak or comprehend, so they have difficulty getting words out and understanding in. The second cortical signs are neglect and agnosia. Neglect is typically the reduced or absent awareness of stimuli on the affected side of the body. This is like where you touch both arms at the same time and they only recognize you touching one arm as they don't feel stimuli or recognize stimuli on the other side. The second is the agnosia. So this is the unawareness of a deficit or a body part. You can show them their hand and go, whose hand is this? And they won't even recognize that that's their hand. Or they can be completely weak on one side of their body. They don't recognize that side of the body, so they don't realize that they're actually weak on that side. This is typically from your right hemispheric strokes or your right middle cerebral or MCA strokes. And so this is the opposite side from your speech patterns right there. Our third cortical sign is gaze deviation. This is where the eyes and even the head can be deviated or basically fixated or focused on one side. Occasionally the patient may be able to overcome this and as they're following your finger finally cross their eyes over to the other side, but that is often forced in some way. This may be concurrent with neglect as we just talked about. And so as you see in that guy in the green gown there, he has weakness on the left side of the body and his eyes are looking to the right. So as we just talked about with our anatomy, this is a right-sided stroke. His eyes are looking to the right side and he's having left-sided deficits as that motor crossed over right at that brainstem as we talked about right there. So how do we test for gaze deviation? We'll have the patient follow your finger or look to the other side. If they're unable to do this and they're completely fixed on one side, that's gaze deviation right there. Just as a note though, as we talked about, that neglect is there as well. So you may need to stand on their good side, if you will, to actually complete this test. The last of the cortical signs is the visual field cut. This is where the visual centers of the brain are affected by the stroke. The vast majority of these involve the loss of the vertical visual field on the same side in both eyes. As you can see in the picture below, the left half of the vision is blacked out or is a blind spot in both eyes there. This is usually the middle cerebral or posterior cerebral arteries that are involved in this case. Let's now bring that all together and talk about left versus right hemispheric LVO or big strokes. The left side is typically referred to as the dominant side because it controls speech. As you can see, there's a motor and a sensory component, a visual field, and a gaze preference for each of these sides of the brain. Then there's that extra in red there. That's the aphasia or the neglect and agnosia. So on the left side, you have that right face, arm, leg weakness and sensory loss. You have that right visual field deficit. And then as we talked about for gaze, they're looking towards the stroke in the left hemisphere. And then they have that aphasia component. The right or the non-dominant hemisphere is the left face, arm, and leg weakness and sensory loss. They have the left visual field deficit, and then they look towards the right side with that gaze preference towards the right hemisphere stroke. And then they have that neglect or agnosia. All components aren't with every stroke. However, these are the usual components you'll see. As promised, we talk about that other 13% as well. These are the hemorrhagic strokes. There's two main causes for these. This is your intracerebral hemorrhage, where you have a rupture of a weakened artery. This is usually like in your lacunar areas, where you have a small blood vessel that gets worn down over long-term high blood pressure, and it finally gives out and starts bleeding into the brain. The other one is your subarachnoid hemorrhage. This is the rupture of your Berry aneurysm or other aneurysm or vascular malformation in the brain. You have your subarachnoid layer, and then you have the brain tissue itself, and you bleed into that subarachnoid space between the two there. One of the hallmarks of a hemorrhagic stroke, though, is an early decline in mental status. And so you may meet the patient, they may be a GCS of 14, 15, and then perpetually decline through your interaction and transport of the patient to the emergency department. Another thing is that they often are preceded with an acute onset headache. You may be familiar with the thunderclap headache, where there's a sudden and maximal headache in the first few seconds to minutes of the headache. There also may be vomiting associated with a lot of these. The patient also may be involved in an exertional thing like sports or weightlifting or some other Valsalva or increase in blood pressure of the brain in the intrathoracic cavity. Usually these patients are significantly hypertensive initially. You may see blood pressures in the 200s over 100s, mid 100s even. and many of your anticoagulated patients are higher risk for a hemorrhagic stroke due to the thinning of the blood. Alright, that was a lot of information real quick, but I wanted to give you a quick crash course in the anatomy and pathophysiology of a stroke so you had a better understanding and recognition of what's going on with each of them. Feel free to pause the video for a second, stand up, take a quick stretch, grab a drink of water, and then come back and be a little bit fresher. We're going to move right into the pre-hospital care and management phase now. In the meantime, feel free to appreciate the parts of the Texan brain. I'm pretty sure that my taco region of my brain is way bigger than what you see on the screen though. Alright, for those that took a quick break, welcome back. If not, here's the stroke chain of survival. Just like a cardiac arrest, there's a chain of care that optimizes the survival and outcome for our stroke patients here. So that starts with detection. We know that lay people do not recognize the signs and symptoms of stroke like we do. So there's often a delay in recognition and actually calling 911. Many of these patients may go unseen in the emergency department or by us for some period of time. But once they call 911, our dispatchers can actually start priming us and starting to get the cascade events going. So they dispatch us out, and then we get there and we deliver care at the bedside of that patient and then deliver them to the appropriate stroke hospital after that. Once they hit the door, they get that stroke team evaluation, and then we get some data such as a stroke scale to find out the severity and the CTs to evaluate if there's a bleed. And then there's a decision made by the stroke team, what do we do next? So they then decide what kind of therapy. Is there a clot buster or a TPA that's warranted, or does the patient need a thrombectomy to remove the clot from a large vessel occlusion? And then finally there's the disposition. This matters. So the floor, the ICU, and then eventually the rehab is a critical component of the patient's care as well. But what was really important there is that the pre-hospital phase is a large majority of this. And what we do out in the pre-hospital setting matters and starts the ball rolling through each of the components after that. So why does our care matter? Well, pre-hospital stroke recognition has been associated with a lot of good things. First, we have shorter on-scene times. We move that extra pep in our step when we know that we have a time-sensitive emergency, and that has downstream benefits. We also directly transport to the appropriate stroke centers for our patient, and we're going to cover that a little bit more in detail later. We also do a pre-arrival notification of the stroke centers so that the stroke team can prepare and be ready for our patients. When they recognize that they are having a stroke coming in and they're ready, more patients will receive thrombolytics because they're in the window for therapy and the stroke team is expecting to be caring for a stroke patient. And finally, we have a quicker door-to-needle time or door-to-thrombolytics or clotbuster times when everybody is in the lockstep with this. As Dr. Vithalani will talk about, we have the MAMSA system performance metrics. These were developed and agreed upon by the System Performance Committee made up of FRO, MedStar, and OMD personnel. And these were reported to the System Board of Directors to evaluate and see how we're doing clinically on time-sensitive emergencies such as stroke. As you can see on your screen here, we measure the percent of suspected stroke patients with a blood glucose level, Cincinnati stroke scale. If the stroke scale is positive, a LAM score measured, whether we do a pre-hospital notification within 10 minutes of EMS contact, and then if the patient has a LAMS of 4 to 5, are they transported to a comprehensive stroke center? These metrics rely on your clinical care and your documentation. So we wanted to share these with you as they are very important to our system. Also in the back of your protocol set is the protocol quality control measures. This deals with whether we documented a glucose, stroke scale, our alerts, whether we transported to the right facility, and then we thoroughly document the time of onset of symptoms and repeat assessments, including vital signs. We also have our quality improvement measures, which are very similar to the system performance measures. So feel free to look in the back of your protocols at these as well, as these are what you need to document and do on scene. Before we even arrive on scene, our dispatchers are playing a critical role for the care of a stroke patient. Utilizing medical priority dispatch, utilizing standardized questions, they can evaluate a 911 caller. If they recognize that a stroke is possible, they will open a stroke diagnostic tool. You may have seen this in your CAD notes already. And so they use a very similar scale to what we use as a stroke screen out in the field. And when that's scored up, they will give you a probability of the stroke. Obviously, not every one of those is going to be a stroke, but what the value of that dispatch is, and when you see that, is it primes our mind to be thinking stroke and start rapidly evaluating that patient and getting things moving if it is a true stroke. And so our dispatchers get the ball rolling early. So please look at your CAD notes, and this is a highly effective way to get our stroke care optimized. Once we arrive on scene and get our ABC assessment out of the way, our next most critical action is to get a glucose. Hypoglycemia is the #1 mimic of stroke symptoms. It's easily reversible, and it's really silly to miss it. Many a really good clinician have forgotten the glucose and gone full bore into a stroke only to realize the patient's hypoglycemic and they completely resolve after a little bit of D10. Our next critical action is to determine the last known normal, or LKN. This is a situation where we're actually more resourced in the pre-hospital setting to determine this than in the hospital. So we play a vital component in determining this time. For the purposes of this discussion, assume we met a patient at noon with stroke symptoms. If they were last seen at 11, fine. Their last known normal is at 11, not at noon when we meet them with stroke symptoms. Also use all available people on scene. That may be bystanders, that may be the spouses, that may be somebody that they just talked to on the phone. And then a unique situation is wake-up strokes. If their bedtime was the last time they were seen normal, that is their LKN. However, you can sometimes narrow that time. Lots of old people like to get up and pee in the middle of the night. If they walked to the restroom and their spouse saw them normal at that time, that may have narrowed that down and given them a better time than last time they went to bed. So make sure to ask about those things. Also use your scene clues. Look at their phone. Are they texting? Did they call anybody? Did they prep breakfast or lunch or dinner? Did they bring in the paper? Look at all these different things that can help narrow the time frame down a little bit more. This is all important because it determines thrombolytics eligibility. The vast majority of patients will be eligible for thrombolytics in that 3-hour window. We can extend that out in some select cases out to 4.5 hours based on specific criteria. So don't forget that last known normal and trying to get that as accurate as possible for the hospital. Just as important as our last known normal is our pre-hospital history. We may be one of the only ones that can obtain an accurate history here. This is vitally important to our stroke team as they're determining thrombolytics and thrombectomy criteria. So evaluate for any mimics. Did the patient have a recent seizure or any seizure history? Have they had migraines? If they have had migraines, have they had similar symptoms in the past? Also evaluate if your patient's intoxicated or has any signs on scene that they could be intoxicated. Also check for any secondary medical causes such as sepsis. It's also important to obtain a baseline functional status. Is this a patient who handles all of their activities of daily living, drives, and handles their finance? Or are they in a nursing home bedbound with right-sided paralysis and aphasia at baseline? Also get a good medical history. Evaluate for any prior stroke, either bleed or ischemic. See if they've had any recent bleeding from the GI tract or urinary tract. Have they had any recent surgeries or procedures? And then focus on medications. Collect all the medications and get a good medication list and consider taking the pill bottles with you. So we want to take a particular focus on anticoagulant drugs. So Coumadin or warfarin are novel oral anticoagulant drugs such as rivaroxaban, apixaban, or dabigatran. That's Pradaxa, that's Eliquis, and that's Xarelto. Then also focus on injectables such as heparin or Lovenox, particularly in the rehab or longer term care settings. It's important to also determine the last dose those medications were administered, as that matters when we're determining TPA eligibility, as you can see on the right there. One of the last bits of history is getting a phone number. The American Heart Association, or AHA, lists this as one of their best practices. Get the family member or caretaker's phone number, particularly a cell phone, and warn them that the hospital may ask them further questions by calling them or want to discuss treatment options. Even better, bring a family member or caretaker with you to the hospital so they can be directly interfacing with a stroke team. Next, we're going to evaluate for our Cincinnati Prehospital Stroke Scale, or our stroke screen. So we're going to try and capture as many strokes into this as possible and rule out as many as we can. So that's that FAS, or face, arm, speech. We're going to look for that facial droop, have them extend out their arms and see if they have an arm drift or any weakness. And then we're going to evaluate for any speech difficulties, such as aphasia or that dysarthria where they're slurring their words. You can pick whatever phrase you like, but you can't teach an old dog new tricks is the most common one. So we're going to do that, and if it's positive, we're going to move on to the other things. If it's negative, then we can effectively rule out most strokes, but not all of them. If you have a positive screen, then we move into the large vessel occlusion recognition scales then. So you may have heard of a lot of different catchy acronyms such as CSTAT, RACE, FAST-ED, StrokeVan, MEND. However, several years ago, we picked the LAMS scale for our system. Let's go over our LVO recognition scale. So this is the LAMS, the Los Angeles Motor Score. There's 3 components, and we're going to add up the score for each of those. Luckily, 2 of the components are kind of shared by the Cincinnati Prehospital scale, so that helps us out a little bit. So if they have a facial droop, they get a 1. Then we're going to do an arm drift. Have them palms up, arms out at 90 degrees, and have them hold them up for 10 seconds. If the arm slowly drifts down, then they get a 1. If the arm completely drops right away, that's a 2. And so if they drop both arms, you should interpret that with some skepticism, and that may be due to poor effort or something else going on, less likely to be a stroke. Then have them move on to a grip strength. This is very similar to our pulse, motor, and sensation exam in a trauma. So have them grip both hands and squeeze. If one side is weaker than the other, with their grip, they get a 1. If they have no grip on one side, they get a 2. Add up those scores then. If they're a 4 or a 5, that's considered an LVO positive score or a positive LAMS. Few people have asked me, well, how good are these stroke scales and screens anyways? So I want to teach you a little bit of statistics, and it's particularly around sensitivity and specificity. So imagine you're testing 100 people for a disease. 90 are healthy, 10 have the disease. Use COVID for example. 90 don't have COVID, 10 have COVID. For test sensitivity, if a test was 0% sensitive, no one with the disease was positive. We literally picked up nobody who was supposed to be positive on the test. If it was 100% sensitive, all the people with the disease were picked up and were positive. As far as test specificity goes, 0% specificity means that no healthy people tested negative. Literally every single healthy person tested positive, which makes no sense for a test. That's a bad test. However, if we have 100% specificity, all healthy people tested negative, as they should. So that's a really good test there. So how does this work with our Cincinnati stroke screen? Well, it's a screen. We want to capture as many people as possible that are having a stroke and have this a positive test because of that. And so for our sensitivity, it's about 83%. We pick up about 83% of the possible strokes. However, we miss about 17% of those still. Also, we know that every person that has a positive Cincinnati doesn't have a stroke. And so for our specificity, it's about 57%. So about 43% of the time, it's not actually a stroke. So how good is a LAMS at recognizing LVOS? For a LAMS of 4 to 5, its sensitivity is 64%. That means we're not capturing every LVO under the sun, but we are capturing the majority of them. As far as specificity goes though, it's a little bit better, 81%. So for a LAMS of 4 to 5, if they're positive, there's a high likelihood that that patient has an LVO, so we should take that very seriously. We've been asked previously, hey, why don't we go with this stroke scale over another? And so what you see right here is a bar graph of each of the sensitivities and specificities for the different scales right there. Everybody's built a different mousetrap, but what the takeaway from this is that nobody's mousetrap is really that much better than anyone else's. The data and the science is continuing to evolve in this area, and we really do still need a better LVO stroke scale or way of catching these if we can do it. So bringing that all together now, your Cincinnati stroke scale has face, arm, and speech. Your Los Angeles motor score has the face and arm again, and then your grip and a score, but no speech there. So these should be pretty quick scales that we can do rapidly to assess, are they having a stroke, and then what is the severity of their stroke, and do they have an LVO or not. Once we have a positive Cincinnati, we're going to evaluate a LAMS score and then determine the appropriate hospital destination. As soon as that's known, we're going to do our stroke alert. Remember, our system performance metrics are to do that within the first 10 minutes of medical contact. So this should really be a bedside or a couch side stroke alert. Remember, this doesn't matter what patch you wear. So if an FRO recognizes a stroke, feel free to call that in if the destination is known. If MedStar shows up, then we should do the stroke alert then if it hasn't already been done. Again, our goal is within the first 10 minutes. I know that's aggressive, however, this is where it gives the most lead time to the hospital. Our other time goal is on-scene time. The American Heart Association, as well as other stroke bodies, recommend a benchmark of 15 minutes from first medical contact to transport. So that's from the first arrival of our FROs to MedStar transporting, and we want to be off-scene in 15 minutes. Again, aggressive, but there's very few things that we can do on scene that overall change the trajectory of our stroke patient. So we can shed that 12 lead or that prophylactic IV access initially and then do those things and route. Again, our goals are glucose, evaluate for history, get a last known normal, do a Cincinnati, and get our LAMS and determine our destination, and then get off scene. Our other goal is to keep the brain safe. We want to prevent hypoxia and hypotension and treat them accordingly if we find them. We also want to treat hypoglycemia. That's also the great mimicker of strokes as we talked about. However, the brain also needs glucose for food. If you're ventilating or bagging the patient, we want to maintain that end tidal 35 to 40 if possible. Also, do not treat hypertension. That is preservative to the brain. We don't want to be giving nitro to try and bring down pressures here. Our goal in all of this is while the brain is burning down, we want it to think everything else is fine. We don't want to have them hypoxic or hypotensive. Well, Dr. Miller, you told me that we got to get off scene quickly. How does the crashing patient goals fit into all this? Well, they still must be met. However, we want to quickly and efficiently achieve those goals. As we talked about in prior CEs, time is currency. We want to use our time effectively when we're on scene and only do the appropriate things that absolutely need to be done on scene, and then get moving en route into the hospital so the patient can get the benefit of that hospital therapy. However, for airway management, many stroke patients don't require airway management. Many of them also oxygenate quickly and easily, and so we can get our A's and B's done quickly. For circulation, get an IV. If you can't get IVs quickly, move to an IO. Pressure bag in fluids and be efficient with that. If you need to move to a pressor, move aggressively to the pressor right there. But again, our goal is to preserve the patient and the brain in the process of getting them to the hospital quickly. Now that we're transporting, let's talk about the two types of stroke centers that we have in our service area. We have primary stroke centers and comprehensives. Primaries have to meet some general eligibility requirements to be a stroke center. Comprehensives have to have case procedure minimums per year or volume. Primaries have a stroke unit and some designated beds for stroke patients. Comprehensives have a neuro ICU or ICU beds for complex stroke patients. Primary stroke centers have a neurologist on call 24/7 or via telemedicine and a neurosurgeon within 2 hours. Comprehensives have a wide range of specialties, including neurointerventionalists, neuroradiologists, neurologists, and a neurosurgeon in-house. Primary stroke centers have the basic CT and MRI diagnostic capabilities. Comprehensives have some advanced imaging. Primary stroke centers just have the neurologist there, versus the comprehensive can handle multiple complex stroke patients all at once. Primary stroke centers can totally do the IV thrombolytics and TPA and the medical stroke management. However, comprehensive centers can do that, and they also have the endovascular therapy for thrombectomies and neurosurgical capabilities for the hemorrhagic strokes and the aneurysmal bleeds. Primaries have minimum stroke staff education and some public outreach requirements. Comprehensive have more. And finally, comprehensives are doing research as well. So that's the main differences there, is that they do thrombectomy primarily, and they have more ICU and more intensivist resources. As far as our service area goes, thankfully we have a lot of primary stroke centers, and they're generally evenly distributed throughout the service area. However, our comprehensive stroke centers we only have 3 of, and they're all centrally located downtown. So that's Medical City Fort Worth, THR Fort Worth or Harris, and JPS. Now let's talk about destination decision making and where we're going. And this is really based on 2 things: the last known normal time and the LAM score. We're going to talk about some protocol changes in just a second on this. There's a couple different transport models for stroke. The first is the drip and ship. We meet the patient at their house, recognize they're having a stroke, and we transport to a primary stroke center where they can get their TPA or thrombolytics. That works really great if your patient needs nothing else and they can stay at the primary stroke center. However, if they have a large vessel occlusion and need a thrombectomy, primary stroke center can't do that, and now we have to do a secondary transfer to the CSC for them to have that thrombectomy. And so that can burn up time and delays the time that that patient could get that thrombectomy then. So this is even more important during COVID, when hospitals are fuller and there's a little bit more time lag between getting them from the PSC to the CSC. The other model is the direct to comprehensive stroke center, where we bypass the primary stroke center in preference to go to the comprehensive stroke center for both thrombolytics and a thrombectomy. However, this does have a possibility for a longer transport time in some circumstances in some patient locations. So which model do we use? Well, in May 2021, we got some pretty good guidance. So this is the recommendations for regional destination plans from the Prehospital Stroke System of Care Consensus Conference. This is basically anybody who is anybody with stroke, including the National Association of EMS Physicians, or NAMSP. They said patients with suspected large vessel occlusion should be triaged directly to a CSC if the total transport time from the scene to the CSC is, for urban environments, less than 30 minutes, and suburban environments, less than 45 minutes. So that's some pretty good guidance. LVO, go to the CSC if you meet a certain time frame. So how does this play out for our system? Well, the central core there you see in purple is a 10-minute transport time to those central CSCs. The pink is a 20-minute transport time, and the yellow is a 30-minute transport time. I measured each of these at 1700 on a Monday traffic. And so the answer is that we can definitely get to the comprehensive stroke centers in 30 minutes for the vast majority of our patients. And so really time factor doesn't matter as much in our service area. So thankfully we can go on our LAM scores and our last known normals a lot more than having to worry about time. If your attention is waned, I ask you to refocus for a second, as this is a very important slide of the presentation right here. This deals with our stroke protocol and is a change in the destination determination. Previously, we had that 3-hour cutoff. If you were over 3 hours, we would do a LAM score and then determine if you went to a comprehensive stroke center. We're now eliminating that. So now if your patient is within 0 to 24 hours of their last known normal, we will do a LAM score if the Cincinnati is positive. So everybody with a positive Cincinnati gets a LAMS now, and that determines where we go. So if they have a LAMS of 0 to 3, aka negative, we still go to the closest stroke center, whether that's a primary stroke center or a comprehensive or the patient's choice. Then if they have a LAMS that's 4 to 5 or positive, we will bypass any primary stroke centers and go straight to the comprehensive, as they may benefit from that thrombectomy or to pull out of that clot. For those patients that are greater than 24 hours from their last known normal, they're not eligible for TPA or thrombolysis, and they're also not a candidate typically for thrombectomy. So they will go into the closest stroke center, whether it's a primary or a comprehensive or their choice. So why not comprehensive stroke centers for literally everybody with a stroke, regardless of LAM scores and time? Well, there's a cost benefit to it. First, non-LVO patients may receive thrombolytics earlier by going to the primary stroke center by them first. Also, we want to reserve those longer transport times for the patients who will actually benefit from it. AKA, if you go to a comprehensive stroke center, you get a thrombectomy. And that LAM score, as we saw in the sensitivity and specificity, has a good likelihood that they actually will have a LVO if it's positive. Also, we want to maintain our primary stroke center's readiness and experience. We want them to be good at stroke, and they need volume to do that. And finally, we want to reserve our comprehensive stroke centers for the most severe strokes. If we go with every stroke to the comprehensive stroke center, we could flood them and make them more difficult to actually care for the complex stroke patients. Once we've hit the doors of the emergency department, the stroke team has a few goals after a quick ABC assessment pit stop. First, they want to get an NIH stroke scale. This is the gold standard for evaluation for stroke and the stroke severity, and will help determine treatment options. The second thing is we want to get a quick CT scan to rule out an intracranial hemorrhage or hemorrhagic stroke. And so ideally we go straight to CT and offload from the EMS stretcher in their patient's clothes still onto the CT table to get that as quickly as possible. Once we roll out a bleed, then they're going to be thinking about, are we going to do thrombolysis? Once they've gotten those two things, the emergency physicians and the neurologists will be determining whether thrombolytics are indicated. And so thrombolytics, or TPA, is usually given in a bolus and then a drip. And so the goal is to break up that clot and basically recanalize or reopen that blood vessel to get flow back. All right, now on to options for large vessel occlusions. If they're within that 3 to 4.5 hour window, they're most likely getting TPA. However, if they're outside that window, their only option is the thrombectomy. We also know that 65 to 70% of LVOS will not recanalize with TPA alone. So these are large clots and large vessels, so sometimes TPA won't cut it. The flip side of that is that if you end up at a primary stroke center and they get TPA, about 30% of patients will benefit from that, so not all is lost. There's been a lot of research recently on thrombectomy, and the number needed to treat, or the number of patients you need to treat with an intervention, is actually quite low and very impressive. It's 2 to 12. We treat 2 to 12 patients before we get a benefit. That's really, really good. Also, there's been a lot of research recently, and thrombectomy has been eligible now up to 24 hours. And so this is a great option for some of your big wake-up strokes. Now on to what actually happens there. As you can see on the pictures on the right, you see the stent retriever. They basically go in, bypass that clot, and then retrieve the clot back out right there. And so on the bottom picture, you see that there's absolutely no blood flow past a certain point on the left picture. And then after that stent retriever was performed, we have good blood flow to that entire area of that hemisphere, again, of that MCA stroke. So thrombectomy, especially as we extend up to that 24-hour mark, is based on the concept of saving the penumbra. So there's an ischemic core that we can't fix. We can't turn back time. However, the penumbra is an at-risk area of brain tissue in that stroke area. If we do the right things, we can possibly bring it back from the verge of life and death into the living and continue function for that patient. So time is brain, but the damage really depends on the collaterals, or the little feeders that give just a little lifeblood left to that penumbra, and also the time to that actual revascularization right there. So the penumbra is really important. And so part of our stroke care of not letting them go hypotensive and hypoxic is to preserve that penumbra. I want to wrap up our lecture now by talking about a few stroke syndromes that our Cincinnati and Lamb scales miss. Things that we want to look out for, and if we just do the scales alone, we might miss. The first of these is the posterior circulation strokes. These account for about 20% of all ischemic strokes. However, about 50% of these posterior circulation strokes are missed by the stroke screen. As we talked about earlier, our stroke screens are really good at catching middle cerebral artery strokes. They're looking at that motor and those speech areas, not the back of the brain functions that we're going to talk about in a second. So these are strokes in the occipital lobe, the cerebellum, and in the brainstem. Some of these may even have no weakness present at all. So again, our Cincinnati and our Lambs are failing us right there. And rarely, some of these also will have that altered level of consciousness, particularly with that basilar, or that single artery that feeds the back of the brain strokes. And so that's a little bit different than a lot of our other strokes as well. When evaluating for posterior circulation strokes, I want you to think of the 5 Ds for the signs and symptoms. The first one is dizziness or vertigo. Yep, there's lots of people that are dizzy out in the pre-hospital setting, and that can be a very difficult thing to tease out from really benign causes that are not that serious all the way up to a posterior circulation stroke. However, you see other things in addition to dizziness, we probably should be putting posterior circulation strokes on our radar. Also, diplopia and double vision. Disequilibrium, or being off balance. Dysphagia, or the actual mechanical problem of difficulty swallowing, where they're choking on liquids or solids. And then there's also dysarthria, or that mechanical motion of the tongue to sound out words, where they have difficulty speaking or slurred speech. Other things to look out for posterior circulation strokes are things like cross signs. An example of this is a left facial droop and a right arm and leg weakness. That's not our typical all one-sided deficits. And the reason behind this is that those motor and sensory components cross in that brainstem, as we saw earlier. You hit the brainstem in the wrong spot, you get these cross signs there. Also, don't forget about that your occipital lobe controls your vision. And so if you stroke out in the occipital lobe, you can actually have a sudden loss of vision in one eye or both. What can we add onto our exams to catch posterior strokes? Well, the first one is a finger to nose test. Have your finger appropriately away from the patient so they would extend their arm completely. Have them touch the tip of your finger and then touch the tip of their nose. And then have them go back and forth as fast as they can. Then have them exchange arms. If the patient is pass pointing or basically missing your finger, or completely missing their nose and touching other random areas of the face, or their finger is moving in a really weird direction, that could be an indication of a posterior stroke. Also, for any dizziness patient or somebody with disequilibrium, we want to walk that patient. Make sure they don't fall and you adequately support them, but if they can't walk, that is a concerning thing that they could be having a posterior stroke. Finally, we can evaluate for nystagmus, or that's that jittering of the eyes. Ear problems typically have a horizontal nystagmus. However, you have a vertical nystagmus oftentimes in a posterior stroke. So if you see jittering of the eyes up and down as you're having them follow your finger back and forth, that may be another indicator as well. While not necessarily a miss of the stroke scales themselves, if we aren't even thinking stroke or performing a stroke screen, we can miss a pediatric stroke. Kids do have strokes. 2.5 to 13 children per 100,000 will have one. And it's about a 50-50 split between ischemic versus hemorrhagic strokes, unfortunately. As you recall, adults were 87 versus 13. There's also a much higher likelihood of a delay to care and diagnoses. Caregivers and providers aren't really having stroke on their radar most of the time. Well, let's be honest, kids act a little bit weird at baseline, and especially in those younger years, they're really hard to assess. Signs and symptoms of a stroke. For ischemic, it's still those focal deficits, altered speech, and the typical things. However, they have a higher incidence of seizures. Not every kid that has a seizure is having a stroke, but some strokes may be presenting with a seizure. For hemorrhagics, they still have that vomiting and altered level of consciousness and headache as usual. However, a big key factor for pediatrics is that 50% of them will have at least one predisposing factor. So we can look for something in their history that may be tipping us off to a stroke. Some of those predisposing factors are here. These are some of the causes of pediatric stroke. So cerebrovascular problems is one of those. Those may be AVMs or arteriovenous malformations where there's an abnormal connection between the arteries and the veins that can easily bleed or stroke, or things like moya moya, which is this top picture right here. You have tons of very small branching blood vessels that can easily stroke or bleed, and that gives that characteristic puff of smoke appearance, or the name moya moya. Congenital heart disease is also a high risk. These children have a higher likelihood of casting emboli into the brain, and they may also be on anticoagulation. Next, there may be infections as a cause, and finally, I want to focus in on one specific hematologic cause, and that's sickle cell disease. Even in small children with sickle cell disease, they may be at a high risk for stroke. The reason for this is that these sickle cells can actually clump up together and cause an occlusion of some of those blood vessels. So any child with focal neural deficits and a history of sickle cell disease or congenital heart disease should be treated as stroke until proven otherwise and transported to the appropriate facility. The final category of things we may miss are transient ischemic attacks, or TIAs. The AHA and American Stroke definition is a transient episode of neurological dysfunction caused by focal brain, spinal cord, or even retinal ischemia or poor blood flow without an actual infarction. There's no dead tissue there. Typically, these last less than 1 hour and oftentimes less than 30 minutes. That's why we miss them. We come in and the patient's back to normal and they don't have any deficits, and that's where we do a stroke screen, we don't catch anything, and think they're fine. However, TIAs are a harbinger for badness. Just like angina in a heart attack, the TIA is the brain's angina. There's a narrowing due to atherosclerosis, or they threw a clot that happened to go deep enough that they didn't present with a stroke. And so about 15% of strokes are preceded by TIA, and they carry about a 3.5 to 10% risk within the first 48 hours of having a stroke. So take these very seriously, and these need to be transported for further evaluation. All right, let's wrap everything up now and go over our take-home points. Cortical signs are indicators of large vessel occlusion. That's aphasia, neglect, agnosia, gaze deviation, and visual field deficits. Hemorrhagic strokes often present significantly hypertensive, they have a bad headache, sometimes thunderclap in nature, nausea and vomiting, and an early decline in the field. On-scene priorities are a glucose, to rule out that as a stroke mimic, and then we want to get a last known normal, and focused history. That focused history should be ruling out any obvious mimics, evaluating their functional status, any really significant medical problems, and any anticoagulation they're on at home. We want to get a good phone number for a family member or caregiver so they can speak to the hospital about treatment options and any other questions. As we talked about, our first medical contact to transport goal is 15 minutes. We want to get in, get our on-scene priorities done, and then get off-scene and do everything else en route to the hospital and get that patient safely and efficiently to the hospital for therapy. We want to expedite meeting our crashing patient goals. Yes, they still apply, but we need to get them done as quickly as possible. Our goal for a bedside pre-alert is within the first 10 minutes of medical contact. Figure out your Cincinnati. If it's positive, get a LAMS, determine your destination, and call a pre-alert. Doesn't matter which hat you wear, MedStar or FRO, you can call in that pre-alert. We're going to do our Cincinnati, and then every single patient with a positive Cincinnati will now get a LAMS score. We also want to determine our last known normal, and if it's less than 24 hours, then our LAMS drives our decision making as far as where we transport the patient. A LAMS score of 0 to 3 is a negative test. They can go to the closest primary stroke center or comprehensive stroke center. For a LAMS of 4 to 5 or a positive test, that's at high risk for a LVO, and we want to go to the comprehensive stroke center in case they need a thrombectomy. Remember that posterior circulation strokes have the 5 Ds for the signs and symptoms, and they may be missed by those stroke screens. Also think about pediatric strokes in the right setting, and also don't forget about your TIAs. So those are your take-home points today. Thanks for your attention on the lecture today. I hope you learned something new. And as always, you can reach out to myself or anyone in the OMD with any questions. Otherwise, y'all take care and be safe, everybody.